Okay. Hello, everybody who is joining or who has already joined. Thank you for being here today. I know that it's a particularly tough day. It's Blue Monday, and also there's so much going on globally that's going on in the US. There's just a lot that we're all carrying, and I think just digesting in real time. And so I just wanted to preface with that first, and that I appreciate you being here and making some time to be a part of this conversation with us. So thank you. And I also want to thank Unsinkable for lending their social media and Zoom room and everything for this conversation to happen. Very grateful. And for helping me out on the tech front. So we appreciate Unsinkable for that as well. And I want to start with a little kind of excerpt of a poem that I came across in a workshop not too long ago. And it says, sometimes we rub our fingertips raw from searching the wall for a light switch. And I think that's a perfect segue into kind of the origins of this conversation and where this all started. And Lamplight is a project that I began back in 2020 when my therapist died by suicide. And this was somebody who had helped me through multiple suicide attempts of my own, all throughout my entire 4 years at college and for my year afterwards in 2020 when I graduated. And so losing him was just, I still have no words for that. And I really wanted to try and do something, initiate something, whether it was a conversation or funding for mental health care providers. And that I say that as an umbrella term to talk about this, to talk about the fact that they struggle with their mental health too. And being a quote unquote expert in something doesn't make you immune to struggling with a thing that you're supposed to be an expert in. And expert, you can argue is not maybe the best word. But I think this is a really important conversation. I'm so grateful to the three wonderful people who I have here today to chat about this. And we are going to dive into a really, really, really good conversation about how mental health care providers experience their mental health difficulties in professional settings and in the field, et cetera. And so without further delay, I will allow our three wonderful panelists to introduce themselves and maybe share a little bit about why they're here, what brought them here, and why this conversation means so much to them. Désirée, why don't we start with you?
Sorry about that. I couldn't find my mouse for a second. So thank you, Michaela, for that beautiful opening and also for that lovely poem. I think that just like anchored us really nicely for this conversation. So yeah, my name is Désirée Jones, and actually this year is my 20th anniversary in this field. Um, which a lot of people make jokes about that ages you, and I love that. I love getting older. I love growing and changing. I love the different things that come up every day for me. And I've been a psychotherapist for so long, but I didn't start as one. I actually was not dissimilar to one of my fellow panelists here. I was on my way to being a psychologist, and I trained in Wales, and I just quickly realized it was a different field I was interested in. I really wanted to get involved in therapy. And so I took on that challenge. I've been, in frontline, I was in frontline therapy work in public and private sector for ages, and then moved my way into management. And now I have the absolute pleasure of being the clinical operations director at Shift Collab, which is one of Canada's largest group practices. And, has some of the most remarkable therapists I've ever had the pleasure of working alongside. We have some incredible conversations, which is really wonderful. And what brings me here is I love this topic. And Michaela, I think it's incredible what you're doing and what you're doing in honor of your therapist, but also in, I think, an extension and honor to anybody who is in this mental health world. This is very, very challenging. And as we've talked about a number of times, therapists they are unseen in a lot of ways and treated like they're supposed to be these oracles of perfection. And that's what brings me here is I'm a fierce champion for our mental health practitioners, and I want them to be seen in all their messy, vulnerable ways.
Thank you so much. Chika, do you want to go next?
Absolutely. So my name's Dr. Chika Oriuwa. I'm a psychiatry resident at the University of Toronto in my second year and have kind of been halted in my second year for the last few years because I've been on my maternity leave for the last 3 years. So I'll be going back soon. I am a mother of two beautiful toddlers who are sleeping quietly in their bed. So if I'm a little bit low, it's because I'm trying not to stir them. And I am a board member of Unsinkable, which is the charity organization that is putting this on. And I'm also an author and a public speaker. And this particular topic is so resonant with me because, of course, being in the mental health field as a future psychiatrist, psychiatry resident, I have always been so vocal about the importance of mental wellness, but I also, through my recent memoir, unlike the rest, I just published it, I spoke for the first time ever very publicly about my experiences with disordered eating that I experienced just prior to medical school in the first year of medical school, and how that obviously significantly impacted my wellness as I was training to become a doctor. And I talk a lot about kind of the intergenerational traumas that come with being a first generation Nigerian Canadian woman and really having to confront not only the stigma within my community of having disordered eating, because it's not a topic that is frequently discussed within the Nigerian slash like Black Canadian community, but then also having to confront this topic of what does it mean when your, psychiatrist has a history of disordered eating, because as it was mentioned by Desiree, like we're kind of seen as the oracle of like you should know better. And in fact, when I was doing my book promo, doing my media tour for the book, I was asked on national TV, like, how did shouldn't you not have known better as a doctor than to have struggled with disordered eating? And that's when it clicked for me that we need to get the message out there that doctors and therapists and mental health clinicians are still human. We are still fallible. We struggle in the same ways and oftentimes struggle more in different ways. And so being able to have a space like this where we can discuss that, especially on a day like today that is overlaid with so many reasons to kind of be sad. It is such an important topic. And so yes, thank you so much, Michaela, for creating this space.
Thank you so much. And Rosiel, would you like to go now and also share a little bit about the wonderful research paper that you wrote that inspired this conversation in particular?
Yes, thank you. It's really wonderful to be here with you and be here with everyone watching and joining us. So my name is Rosiel and my pronouns are they, them, and I'm in Australia on Gubbi Gubbi country. So I'm a lived experience researcher. I also have a background in peer support work, and I did my training as a professional psychology trainee, which is what inspired this paper, but largely what inspired me pursuing psychology as a profession before I started my PhD, which I'm now in my final year of. So I set to finish this year, fingers crossed. I have a long history of being in the mental health system. So I was in the mental health system as a child. So through my lived experience and through the trauma of being in the mental health system, I really felt I would like to be a person who understands what it's actually like experiencing the harm that can come through not only, having experienced trauma and complex mental health difficulties, as a child, as an adolescent, as an adult, and the revolving door and inequities that, can happen for people and why you know, someone can be so vulnerable in those systems and then, you know, cycling in and out and in and out and experiencing systems of, you know, blame and experiencing internalized ableism and all of these things that happen, the pathologization, those narratives that then you internalize, and, you know, how hard that is and how destructive that is and what it does to your sense of self. And then how hard it is to heal from not only what you came in with, but then what you come out with and then keep going in and out with. But then no, experiencing the power of having someone show you even an iota of compassion, and how truly life-changing it is when someone would share with you a little bit of lived experience and to see you with hope and to see you with the power of your own healing instead of those pathologizing narratives. So I was essentially what got me through so many years, and I was still in while I was studying as a trainee, still experiencing complex mental health difficulties, still navigating healing my own trauma, still experiencing long-standing anorexia, still, you know, I was in remission from psychosis, but still, you know, had a diagnosis of schizoaffective disorder and remission. I'd experienced severe trauma from these mental health system experiences, you know, being in restraints, being in seclusion, truly horrific trauma from those systems of care. But I was essentially, it was driving me to enter these harmful systems and feel like if I could just be one person that is, if someone is entering these systems that can do a lot of harm and they encounter me and I'm trying to be a person that wants to show them compassion, that is worth fighting for. That's what I was, you know, coming into this with. So I wrote this paper because, you know, while doing my traineeship, I encountered more harm through a culture of stigma within the profession where, you know, I was working as a peer support worker. I was also doing mental health advocacy work. I was open about my lived experience. I, you know, was doing guest lectures. I was speaking about lived experience. And so because I was open about that lived experience, while I was doing my, doing my master's, then people were questioning, should this person be a psychologist? And they reported me to the psychology board, and I underwent 3 years of, you know, surveillance and what amounted to a community treatment order. And through this, I had very severe impacts to my mental health, and experienced another suicide attempt, having previously already been a suicide survivor. And because of the significant impact of that experience, again, I thought about how can I look into the meaning of this experience and think about this can't only be affecting me. How many other people have been endangered by these cultures of stigma that are baked into our profession from our training, into, you know, keeping people silenced and alone. When you're struggling, we're not being afforded the opportunity for post-traumatic growth, or, you know, the understanding of vicarious trauma or burnout that happens in the profession. It's, you know, a astounding hypocrisy that it's like not believing in people's capacity for healing, that you're saying if a person has experienced struggles, you know, that they don't deserve to be a leader or a beacon of light, or, you know, they can't grow and heal. But that is the foundation of psychology itself, as a clinical body. So it's a very strange paradox. So then I started to research it for this paper, by using my experience, and thought, sharing this story from what I've experienced, you know, my career is over, but at least I can use this to share for other people and explore this more.
Yeah, and we are so grateful that you did, because it's such an impactful paper. And once we kind of get the conversation going again, I'll drop a link in the chat for everybody who's listening, if you haven't had a chance to read it. Just a really, really really good look into what these experiences are like. And so thank you for writing it and for the vulnerability and bravery it took to do that. So very much appreciated. And I want to kind of dive into this idea that I know you mentioned in your paper that there's very limited evidence that clinician mental health struggles are actually sources of harm or danger to their clients or to anyone they work with. There's like almost no evidence for that, even though that's kind of what you were talking about. And there's a quote, I'll quote something from your paper that I'd love for us to kind of talk about. And it says, rather than stemming from psychological or bodily malfunctions, disability is defined as a socially occurring phenomenon imposed by a disabling society that fails to accept, value, understand, and adapt to the diverse individuals and differences. And I'd love for all of us maybe to kind of unpack what that means for us, and kind of what it means to be in the field, be in working in institutions like et cetera, where that may be true and yet it is not practiced. So I will kind of leave it open to anyone who wants to begin and then let you all kind of go off of each other. And I'll get that link for everybody too.
Yeah, so that quote is from it's an explanation of the social model of disability. So first I had explained a little bit about the different models of disability, starting from the biomedical model. So understanding mental ill health as being a symptom of brain diseases. And then we have the psychosocial model, which is acknowledging that you have like biological factors that might be contributing, and then psychosocial factors that might contribute to mental ill health factors. And then you have the social model of disability, which is saying that, people have diverse factors to their psychology and their body, but if society is not accepting diversity and difference or valuing diversity and difference, is the person actually disabled, or is it society itself that's causing those power asymmetrics, and it's causing a disabling environment, and it's not a person themselves that's disabled, it's the environment and the structures around them that's disabling.
Yeah, I think it's really interesting because I grew up in a time where in a classroom, the children who had some neurodiversity, whether it was learning difficulty or, ADHD or what have you, you were really treated as an outcast in the classroom. And so that was in the 80s. And I remember it as vividly as anything. Like it was extremely punitive, and people would yell across the classroom, like teachers were encouraged to discipline in that way, to yell about whether somebody had taken their medication, and they would throw rulers at them and things. And I remember this in Canada in the 80s. And recently I've heard that no, they don't do those sorts of things anymore, but there's still a lot of inappropriate sort of, I don't even know if inappropriate, so it's more subtle. And so they're still doing that. And then, I kind of look at like, well, is this like we're doing it in every system? We're trying to fit people into boxes and telling them that they need to behave a certain way in order to fit in and in order to be accepted. Um, and to your point, and I think this is a really important point, the basis of all, these models really is that there's some way to heal and to be treated. And yet there's also this extremely powerful colonial way of thinking where we need to all fit in to a certain box. And I certainly was trained like that. I have a very interesting story, actually. I think it was 2003. I wrote a paper in Wales, and I was interviewing, it was called The User's Voice. It was published. And I was interviewing all these wonderful individuals who were brave enough to meet with me, who were self-proclaimed to be people that cut themselves or gouged. So people that would say they did one of the two. And they were in the mental health system at that point, considered the most quiet about what their experience was in the mental health system. So we had research in a lot of areas, but self-harm, it was very difficult to get anybody to speak. And so I got 2 samples in Wales, in the mid and the south. And I vividly remember this one guy walking up to me, and he was so scared. I did a survey and I got individuals to come to focus groups, and he was so scared. And he said that I can't remember what his title is, this is so long ago, but he worked in a hospital. And he was so nervous about his name getting out. He was just like, I just don't want anybody to know. That's 2003. And I went through this when I was trying to get into this, like because I also obviously have significant lived experience, and I struggled whenever anybody heard anything, trying to keep it quiet and not say anything. And I just think about where this all began, and I can see myself in school in the 80s, and then I can see myself in university and being told, thou shalt, and, no self-disclosure, and you basically are this, robot. And then I can see that gentleman walking up to me, trying so hard to connect. He just wanted to connect with somebody. And here I am in 2025, and I'm still hearing the same stories from therapists. And that just shocks me that we're still in this position where we are having to be put into these perfect, domes of a person that doesn't exist. Because like, to me, I'm like, we are all perfect. Like, this is who we are. Like, there is no perfection that is out there. I don't know what that is. So it strikes me, and it's hard to hear, but it is so important for us to say it out loud, that it is in a lot of systems that we are currently living through.
Well, in terms of disabling environments, I think the pandemic was a perfect example of the widespread ableism. There was such a collective trauma, I think, for many disabled and chronically ill folk, that these systems have always existed. It was always possible to increase accommodations and accessibility by, increasing, online accessibility, but the willingness was never there. And I think that is not being talked about, or needs to be talked about more, that how much grief and pain that caused for so many people, of having experienced that and feeling so abandoned and so devalued, that then seeing like society rise so quickly to provide that for the collective masses, but not having the willingness to do that, to provide those accommodations to people who needed it beforehand. Because, even I just, touched on it briefly in this paper, that I've been asking for in my disability support plan. We've been required in my master's course to have 100% attendance for my master's course. That's ableist. You 100% attendance or you fail. Now, how can someone with a disability have 100% attendance to class, or just anyone, like anyone? But particularly if you have disability, and, I don't drive. Wasn't able to, I've never been able to learn to drive, because of medical instability. But, making it to class 100% of the time, or if you have a day when you're unwell. So I was set up to fail. Like, if you have a day you're struggling, you're not able to attend, and you're at risk of failing your entire course that you've studied years and years and years for. And then if you repeat the course, you're at financial instability. Like, it puts you into a cycle of disadvantage. So then I'm asking, can the classes be recorded can the lectures be recorded? And they're saying, no, we couldn't possibly do that. I found out, of course, after the pandemic, they started recording all of the lectures. So it's like they were always willing and able, they were always able to do that. They just weren't willing for, you know, a disabled student or other disabled students. And they did it for other courses, but they said for, you know, my Master of Psychology course, it's too sensitive. And I said, but the content we're doing is just lectures. Like, we're not talking about real clients. Or if we did, could you just not record that content, or could you anonymize? You know, all of it was anonymized anyway. We were never actually talking about clients by name or anything like that. We were always doing hypothetical case examples. So whenever I argue that, but yeah, I think those are a perfect example of disabling environments.
Don't want to belabor the point too much because I feel like both everyone else has made such brilliant contributions. But I just wanted to toss in there another anecdote that really came to mind when Desiree was speaking, and that was when I was actually in an organizational psychology course, and it was a psychologist that was teaching it, and it was, I guess I won't say the name of the course because I don't want to, you know, I don't want to identify this person. But I remember because she wanted us to write some kind of call to action. And for me, I'm a poet. I feel like I didn't mention that before, but I'm a poet. And so I wanted to write a piece of poetry about my disordered eating because that was in 2014. And so I had experienced my first like time with disordered eating, and in my life I've only had like two like quite severe experiences. And so that was after I had like recovered from the first one, and I wanted to write about it. And she pulled me aside when I showed her like the first draft of the poem, and she said, "Don't ever let anybody see this or hear this." Or she's like, the number one thing that you have to remember, and she's like, "Oh, and you want to go into medicine too?" Or she's like, this is broadly applicable for any kind of corporate or organization, that you don't want them to know your weaknesses, you don't want them to know your vulnerabilities. And this entire course was all about organizational wellness. So it was just so ironic. I was like, isn't the whole point is for us to be able to try to strive towards our wellness? But it was more so about, this is how you like rise to the top, and like not let anybody know your weaknesses, because then that's where they will attack you. And at that time, I viewed it as like, oh, she really cares about me. And she just, it almost felt like maternal, protective, it was very like, you're destined for great things. Like, don't derail your success by exposing yourself in this way. Um, and so for many years, I kept it as a secret. And it was only this past fall that I have ever publicly spoken, even though I've been a public speaker and have been doing so much public facing advocacy for almost a decade. And I, never shared that until now. And that's because, that little voice in the back of my head of like, don't share this because people will lose respect for you, which was such a dangerous sentiment to embed into a student's mind. Like I don't know, 21 when like I was in my third or fourth year of university. So I'm even younger than that. I must have been like 19 or 20. I was like so young, so impressionable. And I think, what Rosie was saying is so incredibly profound when it comes to systems that create disabling environments that make it so difficult for individuals to actually be able to engage. And it's very interesting sitting and hearing this, because I have a lot of cognitive dissonance when it comes to being in psychiatry. Like I really grapple, and I find that a lot of my co-residents also struggle with this. We see the profound harm that this profession can do, and so we almost want to enter it because we want to be the agents of like reversing that. But then you also feel like your hands are tied, because then there are certain circumstances where you do feel like certain interventions are required. And it can get so, for us, like just the ethics of all of this. And I know that both Rosie and Desiree and even Mikhail, like I'm sure you guys can appreciate being in that position where you are the practitioner and you do have this incredible responsibility. And yet you also know of the like horrors that the patients are experiencing. And especially when I worked in the child and adolescent inpatient unit, some of the most devastating things I've seen in medicine were in those 4 months. And I, you know, I just recall so many patients just expressing this, like, what you're doing, or what this system, what this institution is doing to us is like so damaging. And yet I felt like I was a part of that. It was just, it's just a lot. So I feel like I'm like quasi apologizing. And at the same time, I'm like, trying to sort out my place in all of that as well.
It's so interesting too, because like when I like that like stigma is present across research as well, like that sharing lived experience. Because when I've written a number of papers that share lived experience and go deeply into my lived experience, particularly of having a long-standing eating disorder that is like quote unquote like non-responsive, and has so much stigma and blame associated with, having decades of, being, and same with schizoaffective disorder, that I had decades of being someone who was non-responsive to treatment. And then you often get blamed as being an intractable patient and, an untreatable patient. And, the harm of that, and being someone who was in and out of hospital, and often people refuse to treat and things like that. But when I was, you know, starting out as a researcher, I was also told, this is something you should absolutely not be writing about, because you will destroy your research career before you've even started. People will think you are, too cognitively impaired to work with. And I was like, well, my writing will speak for itself. And these are really important topics to talk about. I was like, the bioethics of these experiences of like my values are too important to talk about. And I was like, I'm in a position of privilege if I can write about this, and I want to be able to use my voice to talk about what it's like to experience these things, and use that to help clinicians understand what it's like to experience these things, because sometimes these experiences are profoundly misunderstood, particularly things like psychosis and eating disorders, or trauma and the complexities when they all intersect. And so I was like, I absolutely need to talk about this. And if it destroys my career, I would rather live and die by my values, and get those experiences out there. But I had so many people doing the same thing of saying, you should not be telling anyone those things. And before my clinical career was ended because of what I experienced, the stigma and discrimination I experienced, I had the opposite of just one psychologist, clinical psychologist, who was going to be my supervisor at the end of my traineeship, after I'd finished my master of psychology and then had the 1-year internship. She was going to be my supervisor, and she saw my lived experience as a strength. And she said, I see so much power in you and so much healing. It still makes me emotional to think about her, because she was such a wonderful practitioner. And she was like, I know that you will be a wonderful practitioner, and I would love to have you working alongside me. And unfortunately we weren't able to work together in that way, but she wasn't seeing it through that lens. So I think more and more, like, the perception is kind of starting to shift in some ways in some people. But it's so prevalent not only in clinical spheres, but also in research spheres, in this idea that, you can't share lived experience because it makes you fundamentally impaired. Which is so interesting, because many people, go into this field because they have their own personal lived experience or people close to them. And it's like this obvious, but, open secret. And yet we also know that concealment of, personal experiences, or painful experiences is also associated with mental health difficulties and distress. And that's all over the research as well. And that stigma is associated with more mental health distress. Internalized stigma is associated with more mental health distress, and yet it's being perpetuated. It's just, yeah, a very, very sad, strange thing that this culture of mental health stigma is doing, and cultures of ableism are doing.
Yeah, absolutely. And I think it points to, I mean, you've all mentioned it in a way, how important something like autoethnographic, like writing and speaking is for researchers and mental health care providers, whether that's an essay or a book of poems or a research paper. I think there's many different forms it can take. And I mean, autoethnography is more of a research practice, but I think there's a broader conversation around that and how to make that a more embedded part of all of this. And Désirée, I think you alluded to at the beginning, like the colonial roots of all of this. Like, I think that really is what decolonizing mental health care, mental health, the experience of mental health care providers have, researchers have, is talking about this really honestly and openly and getting to the root of it. And so I'm curious actually what all of your experiences were kind of like with, you know, making that choice, to be honest, to be really true to yourselves and share your experience. And even amidst all of this, we're talking about, you know, the sphere of mandatory reporting, among many other things. So yeah, I'm curious about your experiences with taking that leap.
Actually, it's a really nice question, and it's interesting because it also changed for me depending on the role I was trying to get into. So, you know, we talked about this earlier, but I think it's important to touch on as well. It doesn't matter how far away the mental health history is, it never ever stops being on you. And when I first wrote for Unsinkable, I called it my life sentence as opposed to my death sentence. I have to learn how to live with this. I am, I'm no longer seeing it as something that means I have to actually end my life. That I'm like, because I think a lot of the suicidal thinking also comes from the fact that you're told this is bad and this is wrong. And so it just spins. So I kind of came to terms with that. But no matter how much you're told to shh and say nothing, it doesn't make it better. So, you know, when Chika was saying earlier, I had to, it's like, it's who I am. Like, I have to say it. I have to come out with it. And so she made that decision. That's what happened to me. Like, I just couldn't hold on to it anymore. And I was like, I don't even know what it is. It's almost like, you know, career be damned. Like, if I have to lose that, at least I will have not ignored this anymore and I've said it out loud. So it's interesting. I'll quickly say this story because whenever I think about it, I'm still shocked that it happened to me. So I was working for this big company and I was doing very well, and I got an opportunity, came my way, and it was going to be this first time where I was kind of launching myself into management. And the reason I had gone into it, and we've all kind of touched on this, is I really was like, I am going to protect the front line. I am now going to be like, I'm there. So I finally got this position at a very, like I've gone through the interview process, references, right? Like the whole shebang, several interviews, by the way. And then they send me a letter and say, by the way, your doctor needs to fill this out. And it's about your fitness to work. And it's like I'm working overseeing therapists. Like it was a bizarre. Anyways, so I go to my doctor. My doctor's I've known 20 years. I have not spoken to her about any of my, issues that I had, and, in the last, I don't know, 10 years. And I walk in and I'd had a significant event that lasted forever when I was young and I was hospitalized, etc. And sit down in front of her. She doesn't even look at me. She turns her back and I show her the form. She fills it in. She turns to me and she says, good luck to with the job, hands me the form. And on this form, which I have to now hand into HR, is all my mental health history. I was in shock. So I ran out. My now husband, my boyfriend at the time, was sitting there just looking at me. I had tears in my eyes. I was just like, I was shocked. And I was like, I'm demanding to see this doctor. And she won't meet with me. So I have to book an appointment. And I meet with her, I don't know, a week later, 2 weeks later. And I asked her, I was like, what are you doing? Like, you can't, this is going to ruin me. Like, basically, right, is what I'm saying. And she looked me dead in the eyes and said, because you're as bad as the German wings pilot. If you remember, that was the person that drove a plane into the Andes and killed 150 people. And the doctor said this to my face. And I remember sitting there in shock. And I'm like, what am I supposed to do? What am I supposed to do? She wouldn't change it. She's left the room. And so I called the manager of this position. And you think about it, I've been vetted. I've had my references checked, my resume. What the heck more do you want from me? And it's been said already. I'm in this field and I'm really good. I know what I'm doing. And I'm coming with this lived experience, which means I'm probably even more of value. And I've got so much compassion. And so I called this manager and I was like terrified. I didn't know what to say. I don't remember exactly what she said, but she was just like, she didn't even know that was part of the process. She was like, oh, I didn't know. No, 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 no. I don't remember all the details. And so she asked me at the end of it to black out what I didn't want in there. And I really, truly believed when I walked in that day with the blacked out form, I was not going to have a job. And I'm very grateful because I don't actually think they knew what to do with it. And I ended up with the job and I was there for a long time. But it was striking to me, that's not that long ago, by the way, that this didn't matter, that I had stopped. And so, of course, I don't talk to my doctors. I don't tell them what's going on. This is always there in my head, right? Like, well, when's it going to come back up? When's it going to be thrown back at me? When is it safe to say something? Because it can impact my life insurance, it can impact my jobs, it can impact everything. So we're told, and that we're supposed to say something, do something, get help. This is what we teach our clients. And in the back of my head, I'm like, the trust is broken in so many places. So I share that story because I'm always like aware, like, it's very difficult for people to speak up. And so when we do, and Rosie, I can't commend you enough for your paper, because I look at it and I'm like, this took so much guts, like, to do, but I also know it's the only way to live. Like, we have to be authentic, right? And just to say what happens and speak our truth. I believe, Michaela, you're right. That is the path to breaking down colonialism's constraints on how we treat and how we rehabilitate.
Yeah, I completely identify with you about like it stays with you and it speaks for like people use it to speak for you having a lack of credibility, and it can be used to take away your power in so many scary
Yeah.
ways. Like I've had that used not only in ways to take away my voice when I'm a patient, to be like, well, you have all these diagnoses, and even when I'm speaking to someone in a very clear, coherent way, they're like, well, you have a history of psychosis, so you have a history of anorexia, so you must be cognitively impaired, you don't understand what you're saying. And I'm like, but I'm very clearly talking to you right now. I am oriented to time and space and perception. We're having a very clear, lucid conversation right now. You haven't done an assessment with me right now that says that I'm in any way not able to make decisions. But, that there's that. And the same way that someone, what I experienced with APRA, they didn't just say, we're getting these reports from a psychologist and a psychiatrist and a GP about how you've been doing the last year. They wanted my entire psychiatric file stemming back to when I was a child in the mental health system, which was just a complete abuse of power, and people who weren't even psychologists were able to see that. Just a revolving door of anyone who went through my case, and those case managers who reviewed my case changed very frequently. So it was a complete breach of confidentiality, which was ongoing, a absolutely horrific experience that I went through for 3 years of just this revolving door of people who had access to your private medical information, of the absolute, like your personal, like anything you've told a psychiatrist, psychologist, any psychiatric admission that I'd had over years. People had access to all of that information for no reason other than they thought I might be an impaired psychologist one day when I'd never actually done anything. I'd gone through that egregious abuse of power because of stigma, because of discrimination. And because of that, when I was supposed to be seeing this new psychologist, I was too scared to tell them anything. For it took about a year for us to establish any amount of trust, because I was like, I'm scared anything that I say to you will go on a record and more people will be able to access this. And I was saying, I just feel like I want to say nothing, so that, because I know it takes 7 years for any record to be destroyed, but those records aren't being destroyed. They're being redug up and shared and going on another system and another system. And, what's APRA's system? Do they never have to destroy those records? Like, they're not even beholden to the same conditions of a psychologist for confidentiality. I don't even know what that system is. So I was saying, like, I have no confidentiality, no control over my own medical information. Like, what does that do? Simply, the stigma of having a diagnosis. And we know from research and statistics that, having a mental health diagnosis does not equal dangerousness. But that stigma is so prevalent that even in a psychology profession, they've paired the two together for psychologists themselves. And it's essentially saying we don't even believe in our own profession, that we're saying that this can't be treated, and that post-traumatic growth and healing isn't real. It's so strange that it's like putting up a banner and saying we don't believe in the efficacy of our own profession, and we don't believe in human healing. We don't believe in post-traumatic growth, and we don't believe in neuroplasticity. It was just like the paradoxes were so clear. And even though I would be saying those to the APRA officers, it was just like people saying, well, where you have these diagnoses. It was just very circular thinking, and it was amazing, absolutely amazing. So I definitely identify with your diagnoses speak for you in very very long-standing ways.
Yeah, I was just going to touch on the fact that you also, in your paper, I don't want to go on too much because I don't want to take up all the airspace, but you also said something important about capacity and all the different definitions for it. And I have experienced that even in disability case managers for long-term disability, depending on who you get at any given time, might have a different understanding of how intense your symptoms are. And then that can get reported too, which can be a huge, huge spanner in your career, especially knowing, to your point, that past history is not predictive, like especially with respect to suicidality.
I was just going to add on to what you were saying, Rosie, about how, first, I just want to apologize for how absolutely abhorrent and egregious that experience was for you. It's unbelievable, and yet at the same time, it is so believable because we see it play out in different ways, and so it's just devastating. And one of the things I was thinking of was, who gets to be the arbiter of like what that threshold is of who is too unwell to be, a psychologist or a psychiatrist or whatever, because that's such a slippery slope, right? And I think a part of this, or, and I don't want to start to analyze your situation too much, but I was genuinely thinking, like, I know quite a number of individuals in the in the mental health profession who struggle with, BPD, or they struggle with depression, anxiety, they have complex traumas, they have and yet I feel like maybe where there's even an amplified stigma may be around the fact that you did have that prior diagnosis or carried that label of having a psychotic illness, which in my opinion, that probably more than anything, it was a
Yeah,
fear.
it was definitely the diagnosis, the previous diagnosis of psychosis was what made APRA come down. Because like when I'd said I was a suicide survivor,
Mhm.
and even my long history of many um anorexia and eating disorder admissions and things like that, that was, even though to me I was like that had much more of an impact on my life, and I felt like was more likely to recur under stress. And my
Mhm.
psychologist was like the trauma history, we're very well managing this. And to me I was like, this often has been more debilitating in terms of my energy levels, my medical instability or things like that. So I was like, this is something I very carefully manage. And have being someone with like chronic suicidality that I'm very, very carefully attuned to and very carefully manage. It was as soon as they heard that history of psychosis, that's what drew all of even though I'd been in remission for like years and years and years, and it was so clearly linked to trauma. For
Mhm.
me, my psychologist understood that as linked to trauma, and research shows for many people is very linked to trauma.
Mhm.
Yeah, it was, so some particular diagnoses also for many people. There's a lot of stigma in psychology profession and also in law apparently as well, is if you're, and I'm autistic, is if you're autistic, some people believe that you won't be effective as a psychologist because there's the misunderstanding of empathy, that people don't understand the double empathy problem, and they
Mhm.
think that you won't be able to communicate effectively, which shows that people lack research understanding, and there's the ableism and stigma around neurodivergence and understanding different neurotypes. And so that's another thing that people also have to be careful about sometimes because of this stigma, is also that people can question, should you be a psychologist if you're neurodivergent, which is just another example of that further ableism as well.
Right. And I apologize again that you had to experience that. And, I had a sense that it had something to do with that just because of the, pronounced fear, societal, but I think also within medicine around specifically psychotic illnesses, there seems to be a lot less leniency around that. And it's unfortunate that they weaponized that history against you just to, I mean, effectually, they have barred you from the profession, which is horrendous. And I'm so sorry. Because, you would never see someone go up to a fertility specialist and be like, how many children do you have? Are you qualified to even speak on fertility? Or, going up to an obesity medicine specialist and asking them their BMI before they can prescribe Ozempic. Like you just don't see that. And, it begs the question as to when it comes to, the mental health field, there's so much like self-flagellation and there's so much, you know, there's just so much stigma that's baked into our profession, externally, internally, in like every single way, that it does make it really challenging, of course, to even be human at all. I mean, certainly healthcare practitioners in every field of medicine, in every field of healthcare, there is an element of being dehumanized for sure. But I think, especially in psychiatry, there is that, like, there's such a narrow margin of error and grace that we are provided. And, I wrote my poem, um, Love Letters from My Body, and it specifically talked about my experiences with disordered eating. And I wrote and I performed that like in tandem with the release of my book. It was the first poem was ever able to successfully write, speaking about my disordered eating. And it was also, I could not get through a performance for like the first 4 or 5 performances without just breaking down crying, because it was just such an emotional experience, but also deeply terrifying because I did not know what the response would be. And yet what I think I have found, even though I'm on my mat leave and I'm going back to residency in a few months, so it'll be interesting to see if and how there's any difference or influence, but just from what I gather, it appears that more individuals or people who have like, talked to me, they're just like, I wish that you were my doctor because you just seem so much more in touch with your own humanity. Like you've been through things, and people don't want to go to someone and feel as though they've lived a perfect life, that they couldn't possibly understand what it's like to struggle. I think it is so healthy and important for our patients to know that we have struggled. It'll narrow the gap of them being able to relate to us, of us also feeling accessible, right? And I feel like we need to dismantle that hierarchy of like therapist, doctor up here and patient all the way down here. So I was hoping through releasing that in a very public way, talking about it on national TV and just being so candid about my experiences. It took me 31 years to talk about it, but I finally got there. And I think ultimately I do believe it makes me a better doctor. I think it'll make my patients feel a lot more comfortable around me if they ever had the chance to listen to my poetry before an appointment. Then I feel like they can just come in with their hearts a little bit more open and their guards a little bit more down. And that's all I can honestly ask for
I
out of
think
a clinical interaction.
I think so, because I think there's a level of like reciprocity in seeing that. Like it feels, particularly if you've experienced like a lot of like invalidation and trauma, is seeing someone's willingness to
Mhm.
like know that vulnerability and do that, it creates a shift. Like I experienced that too, of certainly in and coming from a background of peer support work, of people saying to me, I wish you were already my psychologist or could be my psychologist, when I was in training. And I experienced psychologists making disclosures to me and knew the power of it. And certainly in research, having people contact me about papers I'd written, and or after lectures that I'd given. And I think there was an interesting book that I read, which was by Irvin Yalom, who's was a really well-known psychologist, a therapist, and considered a master therapist by some, or referred to as a master therapist by some, just from years and years and years of practice. And he had taken to asking patients that he had a very long relationship with, after seeing them for years, what had stood out in their mind. And he'd reflected on this in this particular book. I think this was Love's Executioner, which was tales of therapies, tales of psychotherapy. I think that this was in this book, but it may have been one of his other ones, but I think it was that book. Where he'd asked some of his clients what stood out in their mind as like a really powerful moment in therapy with him, or anything that had been particularly important to them. And he'd thought originally, when he'd asked a few clients this, that they would say, it was this really amazing quote he'd said that was like this really effective insight. And he was really laughing at himself after hearing this a few times, that often it was just people saying that it was more something that he'd really listened in some way, or had said something about himself that they felt really connected. So they never remembered anything he said that he thought was like a really deep, profound insight. It was much more about the connection and the relationship, and never never something that was like an insight and a deep takeaway. That, not that any of those things wouldn't have helped along the way, but the things that really, really stuck with people was more often something like that. And I think it really does speak to that people need to feel heard and need to feel seen, and need to feel like they're not alone. And that is really important for us to have that, especially when it's something like a relationship where there is that difference in power, that is just part of those kinds of relationships, where one person is having to be so incredibly vulnerable. It does change things if you know that someone is coming from a place of understanding. It really changes things, and it really helps you be able to feel like you're safe and held in that experience, because someone is coming from a different place of wanting to help you through this, and help create a place for you to find your own way and find your own healing through it.
Yeah, I was gonna just say I recognize the time, so I'll keep this brief, Michaela. But I I think one of the things that is very wrong, and I think that's not even a strong enough word, in the ethics and standards and the way we are trained in this field, is we are told very strongly that we are not to self-disclose. And I think it is a big mistake. I think what we're talking about when we talk about inappropriate self-disclosure is very rare. And it's like the therapist that doesn't stop talking about themselves. And that is the teaching. That's the piece that can be taught, not don't ever talk about yourself. To me, I'm like, there is I feel sometimes, I love somebody who was talking about this recently, the difference between storytelling and a presentation. And I'm like, Rosling, the famous statistician, was amazing at storytelling, and he would bring data to life, and he would show you why something mattered. And he would talk about it in this very personal way without talking about himself. And I'm like, that's what we want to do in therapy. We want to connect, and therapy, or even like the best family physician I ever had, he just made me feel like I mattered. He never forgot me. It was just, I still remember as a child. And I think that what people think of when they think self-disclosure is the therapist or the practitioner that doesn't stop talking about themselves. And I'm like, but that's not it. Like, it's literally me sitting with you and connecting and being like, that must be hard. Oh my goodness, I can't imagine. I'm feeling this right now. This is actually making me hurt. Like, what is wrong with being able to connect with somebody at a very deep level? I think that this stoic, robotic thing, it's not, this is not warm. It's not helping anybody. I'm really thankful that I work in an environment where the authentic self is really encouraged. And I hope we see more of that in our public sector so that people aren't scared to tell their story. I remember when I did my story for Unsinkable, I went and told my boss because I was worried. And I hope that we don't have that moving forward, that we can actually speak up, and you can feel free to share what makes sense for you, right? And that you don't need to get into all the nitty gritty. But I think it is a big mistake in this industry to put this huge red mark on anybody that says, yes, I have a kid. Oh my God, how dare you say that you have a child? Like, right? Like, we're told you don't say how old you are, you don't say what generation you are, like, you say nothing. And so you just end up being this bizarre, like, and you look bizarre because you're not answering very basic questions, right? That connect most people together. So anyways, I just wanted to add that note that to me, that is where compassion lives, in connection, is in that piece around self-disclosure and storytelling, and in however you want to do that.
And in peer support, we always learned to tell stories with intention. So it was always thinking about what about our stories we were sharing and how and why we were doing this, how it would affect the person, how much we were going to share, and with what benefit it would have for the person. So, you don't need to share a lot of details. I think that's part of what people think they think of when they think of a psychologist disclosure, that a person could say, I understand how you're experiencing that. I have my own experience of trauma. They don't have to go into what that is, or, they could say, I have been affected by suicide. I lost someone close to me. It could be something like that. It doesn't have to be going into,
The whole
or
story.
I've also experienced depression myself. It could be as little as that, and that's all it takes for the person to be like, this person knows what I'm going through. And it might be that the person then goes, so people really do like recover from this. Maybe, do you still struggle with it sometimes? And maybe they then answer a question back like, sometimes I have like, moments that then like I still struggle. So it might not be that they then go into their whole story. It's just that they've given a person a little bit of an idea that they've had some kind of experience. It doesn't have to be like they sat down and like, told them like this whole deep thing. So sometimes it really is just a little bit of that connection that is enough. for people to feel like they have that understanding and they have that safe relationship. And I think that's part of what keeps the profession isolating and struggling, is that then if people are experiencing distress as a professional or as a researcher or in whatever health field, is that they're afraid to then go and seek support, because they're like, this, I will be reported, this will impact my whole career, my livelihood. So then maybe they continue to spiral, or they just can't access that help without fear of repercussions. And then that's where we get into really dangerous territory, because someone is experiencing more burnout, they're experiencing more distress, more and more and more distress, that it keeps building and keeps building. And then when they can't access that support, the person is more vulnerable, they're more at risk. And then we get into really, really dangerous territory. And that's, you know, when I started looking into research for this paper, I was seeing that. And it's really, really concerning. And then particularly when people are actually reported, they're at even more distress, because then they're even more isolated. They have no one to turn to for support. And then we get clinicians dying by suicide or attempting suicide. And these concerns are really known. I found that it was not only in Australia, but also in England and US that this has been researched. So across different jurisdictions, that we know this is a problem across the profession, not only in psychology, but in different medical fields. And there's nothing, you know, there's nothing really addressing this as a systemic issue.
Yeah. Yeah. And then you get gaslit by the governing board saying, oh, see, we told you that would happen, which is just terrible, because then it just creates this awful cycle and loop. And I want to be mindful of our time, because I know we're almost 10 minutes over. But if you are all okay with one more question, a very, very not simple is the word I'm looking for, but can be a concise answer maybe, because I think what we're talking about really, now that we're like getting into the root of it, is collective care and what that looks like for a mental health care provider, a researcher, and a client, or like anybody in these spaces. What does collective care look like for each of you? And can be a very short answer. I know we're out of time here.
Yeah, I think our systems are currently built on individualistic care and self-care, being that, you know, it's your own responsibility to take care of yourself and your own, certainly in psychology professions or any other sort of medical profession, is your ability to practice is your own responsibility, and we're not looking at the systems and environments around people to think of it's a shared responsibility to create systems that are equitable and people to be able to exist and work in safely. How do we, and we need to be asking those questions about how do we create these cultures that if people are starting to struggle, that they can safely access support, they can safely talk about things, and they can reach out. And you know, what does that support look like? What are the steps that people can talk about this and then be able to access that? And it won't be that they're immediately isolated and that they go through something even more stressful than like being reported to a, you know, body that is then going to put them under surveillance, put their livelihood at risk. And, you know, then it's spiraling even further. But how do we then, you know, wrap support around this person if they are starting to struggle? So asking those questions about what systems of care do we need to create? How can we be part of this? And not just putting the responsibility of care on one person, because we don't live in isolation, we live in systems, and we need to think of care as not just resting on one person, but in a collective system.
Yeah, I thought the way that Rosie summarized it was brilliant. In my keynotes, I often say it's not about self-care, it's taking care of each other. And so very poignantly said, and I don't want to belabor the point, but I absolutely believe that we are not meant to struggle in isolation. And in fact, the number one predictor of longevity has nothing to do with our physical fitness and has everything to do with our connectedness to one another. And so if that is any argument as to why we need to take care of each other and remain connected to one another and truly uplift one another, protect one another, wrap around one another, it's for that reason. It helps us all live longer, healthier, better lives.
Yeah, I think I agree. I'm not everything I think that's been said is exactly where my head went. I'll add, I was a mom, new mom, older mom in the middle of a pandemic and could not go anywhere, see anyone with this newborn baby. And I remember my collective care at that point, and I was just like, I told people this story a few times. I live in the region of Peel. My daughter is going to be 4 years old in a couple of weeks, and I'm still on a wait list for therapy, which is just insane. But and it's hilarious now because I'm like, I don't even know if I have postpartum now. She's 4. Um, but my collective care during that time was a whole bunch of mamas online, and I didn't know what their backgrounds were. I didn't know if they were therapists, psychologists. They were just so real with me, and it was the biggest connection I'd had. And when we were finally able to go outside, we met, and I met all these beautiful people from all different backgrounds, and we did stroller walks, and never knew that connection wasn't just about all these friends that I used to know. It was also about going to, connecting. My boss is going to laugh because I'm going to mention the library. I'm obsessed with libraries, but it was connecting with my community. And Michaela, I think lamplight is collective care. I think that having somebody speak up and say, this matters, and then to have people with, Chika, your background, Rosie, your background, you're in positions of power, whether you like it or not, and that makes people feel like, oh my gosh, maybe I can open up a door and I can say something. um, I have a story and a half, and I never talk about it. And whenever a therapist is struggling, collective care for me is just getting on a phone and being like, I don't know what you think I am, but this is me. And I think it's important that we get vulnerable when it matters so that we can break that down, break down the silos. Oh, nice.
Yeah, I have to say, online communities I found amazing for collective care, particularly as someone who's like quite physically isolated often. Like the amount of collective care I found through online community, disability and in chronically ill community, lived experience community, amazing, LGBTIQA plus community, like huge, huge capacity for collective care. And my psychologist I also think of as
Yeah.
collective care, who's also someone who's shared lived experience with me before and holds hope, incredible hope, and has been amazing for me and just supporting healing and saying I see endless capacity for you for your own healing. So yeah, I think you can find your collective care in many ways, and sometimes it can be hard if you feel like you're isolated and you feel like you're not finding that connection. A good place to start, a really, really good place to start is online, because there can be many like warm, wonderful people willing to just like grab you and bring you in and help you to like join their group of people.
Amazing. And that is such a good note to end on for everybody right now, whether you are a mental health care provider or researcher, anybody, lots going on in the world around us right now, and in all of our communities. Every single one is touched by something. And so I am grateful to all 3 of you for this conversation. And I feel like we need like a part 2. Because there's so much that we got into and so much that we started to unpack, and I have many more questions. And so maybe there will be, we'll see. But thank you to everybody who's listening, everyone who will watch the recording afterwards, and just, yeah, I guess my parting message is for everyone to just take care of yourselves right now. I think, especially on the note of collective care, reach out to the people who you need and who need you. It's a two-way relationship, and it's really, really, really important right now, especially for our folks working in mental health care, working in the medical field, who are responding to so much pain and grief and loss. And so with that, thank you everybody for joining, for tuning in. Thank you to the three of you again for being here and having this incredible conversation. Means a lot to me personally. It means a lot to, I'm sure, everybody who's listened and who will listen. So thank you.
you.